Hey everyone. Today, we are diving into one of the most incredible cancer therapies out there. Seriously, this is a treatment that actually engineers a patient's own immune cells, turning them into a living, breathing medicine that stays in the body. So let's get right into how this amazing science works. So, here's the big question, right? This is the central problem that doctors and patients are up against. What do you do when cancer cells get smart, when they learn how to dodge and weave and resist all the standard treatments? Well, you need a weapon that's just as sophisticated to go in and hunt them down.
And the villain in our story today is a really tough one. It's a particularly relentless cancer called relapsed or refractory multiple myeloma.
Okay, so what exactly are we dealing with here? Multiple myeloma is a cancer of your plasma cells. Those are the cells deep inside your bone marrow that are supposed to be making antibodies to fight infection. But that word, refractory, that's the real kicker. It means the cancer has already seen the standard chemos and frankly, it just doesn't care anymore. It stopped responding, which makes it incredibly difficult to treat.
But these cancer cells have a weakness. They've got a tell, a signature that makes them stand out. They're basically covered in this protein called BCMA. And this signature, this is the crucial vulnerability that scientists figured out how to exploit. This is our target.
So, how do we attack that target? Well, you don't do it with a conventional pill or an IV drip. No, you do it by recruiting and training a living army from right inside the patient's own body. And I want to be super clear about this. We are not talking about some chemical that was cooked up in a lab. The medicine is the patient's own T cells, just, well, supercharged. It's a completely personalized, living therapy. And here's how it's done. It's a pretty involved process. First, doctors harvest T cells directly from the patient's blood. Step 2, those cells get shipped off to a special lab where they're genetically reprogrammed. Third, while that's happening, the patient gets a round of chemo, not to fight the cancer, but to make some space in the immune system. And then finally, the newly engineered cancer-hunting T cells are infused back into the patient, ready to get to work.
Okay, this is where it gets really, really cool. Let's dive into the science of how you take a regular old T cell and transform it into one of these cancer-destroying supercells.
The key piece of technology here is called a chimeric antigen receptor, or just CAR for short. Now, think of it like giving the T cell a brand new supersuit. It's a synthetic receptor that we add to the cell's surface, and it acts like a GPS and a weapon all in one. It gives the T cell this whole new power, the ability to finally see and lock on to that BCMA signature on the myeloma cells.
Now, what makes this specific therapy, its technical name is Ciltacabtagene, so special? Well, a standard CAR T-cell, you could say it has one hand to grab onto that BCMA target. But Ciltacabtagene, it has two. It's what's called bi-epitopic. That means it grabs onto that target protein in two completely different places at the same time.
So why does that matter? Well, this two-handed grip dramatically increases the binding strength. The scientific term for that is avidity. And it makes it so much harder for a cancer cell to escape. Even if it tries to hide one part of its BCMA signature, the T cell stays locked on tight. There's almost no getting away.
The toolkit they use to build this is just incredible. To get the genetic instructions for this CAR supersuit into the T cell, they use a modified, totally harmless virus called a lentivirus. It's basically a delivery vehicle. And those instructions don't just build the receptor, they also include other signals, like one called 41BB, which tells the T cell to stick around and multiply, and another called CD3-zeta, which is basically the big go button that unleashes its killing power.
All right, so the supercells are built. They're back in the patient. Now, the search and destroy mission begins.
Almost immediately, these cells start to multiply, creating this massive army right inside the patient's body. They patrol everywhere, the blood, the bone marrow, constantly scanning for anything that has that BCMA signature on its surface.
And you know what? The results have been stunning. Clinical trials like one called CARTITUDE-4 have shown that this therapy can trigger these really deep and, this is the important part, long-lasting remissions. We're talking about patients where multiple other treatments had already failed. This is not a temporary fix.
But you have to remember, a weapon this powerful is never without risk. When you unleash such a potent immune attack inside the body, there can be some serious side effects. You could call it collateral damage. So this therapy has its own unique set of toxicities. The most common one is called cytokine release syndrome, or CRS. It's basically a massive, full-body inflammatory response that can cause high fevers and drops in blood pressure. There's also a kind of neurotoxicity called ICANS, and unique to this particular drug, there's a very rare and delayed risk of developing Parkinson's-like symptoms.
The good news is, for the most common and dangerous side effect, CRS, doctors have a very effective antidote. There's a drug called tocilizumab that can go in, block the main inflammatory signal, which is IL-6, and basically shut the whole syndrome down.
Now here's a really interesting idea. It's called on-target off-tumor toxicity. See, the CAR T cells are incredibly good at their job. They're designed to kill anything with BCMA on it. The problem is, some of your healthy, normal plasma cells also have a little bit of BCMA. The CAR T cells can't tell the difference, so they kill the good guys right along with the bad guys.
And what happens then? Well, this perfectly illustrates the trade-off. By wiping out all the plasma cells, cancerous and healthy, the patient's antibody levels plummet. This condition is called hypogammaglobulinemia. So they might be winning the war against cancer, but they're left with a weakened ability to fight off everyday infections.
Phew! Okay, that was a ton of information I know. So to wrap all this up and make it a little easier to remember, let's run through a quick cheat sheet for everything we've talked about.
Believe it or not, the drug's name itself, Cilta, can be a great mnemonic. C is for chimeric antigen receptor. I is for the IL-6 release that causes CRS. L is for the lentiviral vector, the delivery tool. T is for those crucial 2 binding domains. And A is for autologous, meaning it comes from the patient's very own cells.
So just take a second and think about what this really means. A single infusion creates a medicine that grows, that lasts, and that provides surveillance against cancer, sometimes for years. It is a fundamental shift in our very definition of what a drug can even be.
And that leaves us with one final, pretty mind-blowing thought. A one-time treatment that becomes a permanent part of your body, offering protection for the long haul. Is this what the future of medicine is going to look like? It's an incredible thing to think about.